Good afternoon, and thank you, Minu, for inviting me to this course again this year. Yeah, I'll be speaking on small pupil, IFIS, and pupil expansion devices. I have a financial interest by virtue of my interest in the company. Now, how many of you would use pupil expander or iris hooks in this kind of a pupil? I guess not many. You will. Okay, good. Well, I started off with this and thought I wouldn't use one, and then when I just injected that viscoelastic and I was coming out, I just noticed a slight hint of iris prolapse. And that kind of, I changed my strategy and went in and used a pupil expander. Well, it went well, and I used the BX pupil expander. But then let's see what happened over here. And we have iris prolapse to the side port. And well, we managed with that. We lived with that for some time. And then here we have iris prolapse to the main incision. Nothing wrong with the surgery, everything going well. So we went ahead and got rid of the iris prolapse, did the surgery, and then we pulled out the B-hex, could be removed through the side port. So that was a huge advantage in this case because the iris was prolapsing from every other port. So with that, I would like to just suggest that now, if you look at it, how many of you would be inclined to use an iris hook or pupil expander? Now, what is important over here is that iris hooks or pupil expanders will not eliminate iris prolapse. They may reduce the fluttering of the iris or the billowing, but what they do is maintain a dilated pupil which provides visibility and safety. That's what is important. So, there was a time when people thought that, oh, Indians are not touched by IFIS and it's a problem in the West, tamsulosin and stuff like that. But then this is a wonderful paper by Shilpa Goyal and co-authors, and here we got some fantastic figures, and the incidence of IFIS is higher in India, and not only that, current use of tamsulosin, alfuzosin, and hypertension are important risk factors. Now, if you look at now, we have a whole lot of literature with IFIS, and that is the list of drugs and systemic conditions which can cause IFIS. So practically every alternate patient that gets into our theater is a potential candidate for IFIS. So no amount of history taking is foolproof, and we will have to brace ourselves for IFIS with every case that we deal with. There's another thing is we need to, well, we kind of find comfort in a certain amount of pupil size. So what would be a safe pre-op pupil size to eliminate the risk of IFIS? People would say 4 millimeters, 5 millimeters, something like that. Well, here's a paper in 2011 by Alessandro Casuccio and co-workers, and the conclusions were that for a pupil 7 millimeter or smaller, the risk of IFIS existed regardless of alpha blocker intake. So these are the lessons, like I said, and IFIS can occur in pupils less than 7 millimeter, and it's important that even women are often on tamsulosin for UTI. And like I said, it does not eliminate the risk of iris prolapse, but does is gives us a constant pupil size, which makes it safer. What is important is to understand that there are two types of small pupils. It's the rigid or pupil, which is non-elastic, and the elastic IFIS pupil. The two are very different in nature. So this is IFIS. Let's see a few cases of IFIS. Now this is grade 1 IFIS, where you just have that fluttering or billowing of that iris over there, and that is something which you can pass off and live with, and it's not very difficult. Now these are all very old videos, and I apologize. We didn't even know the IFIS then. These are something which I pulled out. Some of them may be VHS cassettes which I pulled out. And this was perfectly going, and then the pupil just comes down on me. Nothing wrong with my fluidics, but then you inject viscoelastic and the pupil comes back to size. So that is a very typical IFIS case. And well, this went off well, and then we managed to put in the lens. And now this is, again, even those times we realized that with iris hooks, you are not again eliminating iris prolapse. What we are doing is we are getting a constant pupil size to allow us safe phacoemulsification. So despite my iris hooks in place, even before I could put my phaco probe in, I had iris prolapse, and my iris was frayed like a fishing net. So this is, okay, let's go on. So in summary, these are the take-home messages as far as IFIS is concerned. And the best part is IFIS can occur within 3 to 7 days of tamsulosin intake, and it can occur even after 1 year after tamsulosin has been stopped. So there is no safe method altogether. And we must be very careful about stopping tamsulosin because it really has no value as far as IFIS is concerned on the table. In fact, it may be very counterproductive with patient landing up with urinary retention. We could prevent all these complications by using iris hooks or pupil expansion devices. Like I said, pupil stretching would not be effective in IFIS. It would be effective in rigid and fibrotic pupils. So we have the iris hooks and the pupil expansion rings. These are the pupil expansion rings that have come to the market in the last few years. The ASIA pupil expander, it's a little bulky. It's a double iris hook. Engaging is a bit difficult. It's stiff springs. I've now personal experience with from what others have used and I've heard. And well, this was the Expand NT that came in. It's made of nitinol and it's autoclavable. It has a pretty high profile, and it's that's biplanar design which causes snagging at the incision. So it's not a very smooth entry and exit, and that's why they moved on to what was the Expand NT with a injector. That made the passage into the antechamber and out of the antechamber much easier. But then that wasn't a very great device also. It's there still in the market, but it doesn't look very comfortable. Beaver Vistic eye ring, this has been there. Now it's polyurethane with live hinges. It's a bulky device, slightly thick to consider, 1.5 millimeter. The mid-peripheral antechamber is going to be slightly shallower than the central, and that's where the corners are going to be resting. So it may be a bit of a touch and go, and you may have endothelial touch. Canabrava's ring has been there. It's a PMMA ring. It's a slightly, again, bulky device. It's stiff. You may not be able to use it in all cases because manipulation is a bit difficult. So that brings us to the BHEX pupil expander, which has been there now for almost 2 years in the Indian market. So we have thick, strong flanges. It's a hexagonal device and flexible notches, and alternate flanges are tucked under the pupil margin to provide pupil expansion. I'm humbled by the kind recognition that I've received for this. Now, with the Mulligan ring or its likes, like the eye ring, they are brilliant, no doubt about it, but the fact that they are biplanar and they snag the incision on the way in and way out is what was my problem. So we came out with a new concept, which was the BHEX, which is a uniplanar device. And what we did was we took advantage of the fact that the iris can be bent without any harm. It can be reversibly bent without any harm. And so the device was in one plane where the iris was being bent. I would recommend that you see videos before you use. It looks a very simple design, but you may land up in problems if you don't see videos. What is important is with every iris hook or pupil expander that you use, keep the antechamber underfilled. We have a tendency to inflate the antechamber to get a slightly wider pupil, but that is again counterproductive. It's better to keep the antechamber shallow and inject a little viscoelastic under the pupil margin to create space for your device. So when you inflate the anterior chamber with viscoelastic, the iris gets plastered onto the lens, and that makes our job difficult. So instead, it's better to use a bit of viscoelastic under the pupil margin all around and lift it off from the anterior capsular surface. So that's how you lift it off, and you have space for the device. This is just how we do it. A little bit of viscoelastic in the antechamber, very little, just to protect your corneal endothelium, and then we go under the pupil margin and lift it off with a bit of viscoelastic. You use HPMC also, works fine. And then you go ahead and do your device. If the pupil is 4 millimeter or smaller, I always recommend that you stretch it bimanually because the BHEX is not strong enough to tear a fibrotic ring. So what we need is, it does provide, so how do you identify a rigid pupil? You inject BSS from the side port and the pupil expands momentarily. You know you can get away. It's slightly elastic pupil. On the other hand, if it's something like this, like this, it's a pseudo-exfoliant pupil, it won't budge. And this, of course, is a total giveaway. You can try whatever you want, and you can inject whatever viscoelastic you want, and it's not going to budge. So you need to stretch this to about 4.5 to 5 millimeters to get a reasonable pupil. So unlike the elastic IFIS pupil, the rigid pupil is a fibrous ring, and you can't expect it to stretch. So they are better stretched, stretched to 4 to 5 millimeters, and limited bimanual stretching produces controlled sphincter tears, and you have a good cosmetic pupil. A bulky pupil expander may stretch the pupil but will produce uncontrolled tears, and it's a little unwieldy. That's the trade-off which we have to understand. So this is again another case where I tried peeling off that pupillary membrane, released the synechia, and peeled off that membrane. Didn't really work. So I stretched it to about 5 millimeters, and then we used the BX pupil expander. Yeah, I'm done nearly. And that's when we use the PX pupil expander, and we got a nice round hexagonal pupil, and that helped us do the surgery. We now recommend only the forceps because we have the manipulators out, and this is all there. Okay, the BX has a huge advantage with an open capsular rhexis because you can see the notches, and so this is where pupil comes down on me midway, and we can use a little bit of viscoelastic at the pupillary rim, over the anterior capsular rim, and then when you tuck the flanges under the pupil margin, what happens is you see the capsular rhexis as you advance that flange, and it's an instant confirmation that you have not engaged the capsular rhexis margin. That's a huge advantage over any other device that is available. I think that with that I will close this. Thank you.